pandemic time, and I think it's important that we are able to critically evaluate a paper. So sometimes we tend to glance through the abstract and come to conclusions, but that may not be sufficient to evaluate the quality of the data and the quality of the conclusions drawn. So it would be very nice for us to consider what's important in evaluating a paper. So today we have two eminent speakers, Professor Anuja Premwardana and Dr. Dileepa Edrivira, and the Secretary of SSIM, Dr. Tushara Matthias, will be the moderator today. So without further ado, I think I would like to invite Dr. Tushara Matthias to introduce our two speakers and start the webinar today. I must thank the two speakers in advance for agreeing to deliver their talks at a time like this when everyone is constrained by matters. Over to you, Tushara.
Recording in progress.
Thank you, Dr. Sattva.
Tushara.
Yes, there was a small file. Okay, and to start off our webinar for today, we have the first speaker, Professor Anuja Premwardana. He's a specialist in internal medicine and senior professor in medicine at University of Kelaniya. He obtained a DPhil from University of Oxford in clinical medicine in the field of hemoglobinopathy research in 2002 and has continued clinical work and research in the field of hemoglobinopathies and iron metabolism. His current H index is 21 and I-10 index is 34. Over to you, sir.
Thank you very much, Harsha and Tushara, for giving myself and Dileepa this opportunity. I'm talking about this topic on interpreting a research paper. Let me move on to my slides now. Now, one of the most cited research papers of the modern era states by John Ennis, a Stanford academic, that contemporary research in the field of medicine mostly comes into wrong conclusion. This paper has been downloaded more than 1 million times, and that is for a very solid reason. Now, there's no wonder that there's a great interest in research. There are over 6,500 peer-reviewed scientific journals and over 2 million papers published every year. So whatever you write, you can get it published somewhere. And research data in the same field very often, well, not very often, can give contradictory results. This confuses the reader about its implication, and when it comes to clinical medicine, about its application and clinical significance. Why similar studies would end up giving dissimilar results needs analysis. Now, before we get into the nitty-gritty about individual research, let me briefly go through the different kind of research studies. Research studies are divided into two main groups: descriptive studies and interventional studies. Observational studies and experimental are synonymous. The descriptive studies could be case reports, cohort studies, case control studies, or cross-sectional surveys. And the experimental studies or the interventional studies are our famous clinical trials. So when you look at the observational studies, there are two main types: the cohort studies, where you observe a group either prospectively or retrospectively, or a case control study, which you compare the patient with a a control. For example, if you ask a question like, do thalassaemia patients have MRI changes in the brain? You can do a patient and a normal control. That would be a case control study. Then there are cross-sectional studies, which are essentially surveys at a point of time. And then less often we come across qualitative studies, which are very often essays, opinions, which are not numerical data. Now, what really fascinates our group of clinicians, our doctors, internists, are the randomized control studies, especially in this time with COVID. And in a randomized control studies, the key issues, the key steps is randomization, blinding, and a control. The control could be a placebo or another group. And in any study, be it an RCT or otherwise, for the study to be good quality, there should be adequate numbers. Now, if you ask a question, what is the best type of a study? You should realize that there is no such thing as a best type of a study. It all depends on the research question at hand. And the study should be designed to answer the question which you are proposing to answer. For example, if somebody wants to raise a question, a clinical question, a research question like, is there an increased risk of lymphoma for those who live under high tension virus? You can design a cohort study, study lymphoma and look for those who have an environmental exposure to high tension virus, and maybe a retrospective cohort study, or this could be done prospectively, which is of course a very difficult, time consuming thing to do. A case control study, example, just like what I mentioned before, you can ask a question, is headache more common in thalassaemia patients? Here, patients would be the thalassaemia individuals, controls would be age and sex matched normal population, and there you do a headache survey. That would be a case control study. Cross-sectional studies are essentially prevalence surveys. For example, if you do something like prevalence of diabetes in urban Sri Lankans, which is a snapshot study. Qualitative studies are things which we hardly ever see these days. These are in-depth interviews, which are not essentially dealing with numerical data, where you ask about patient experiences, which are not very commonly seen in medical journals, high-rated medical journals anyway. Now, the question that is proposed to myself and Dilepa is not about this, but was to ask about how best to read a paper. Now, if it is very good to have a clear method of reading a paper and understanding this, because you should be able to read it independently and come to the same conclusions as the authors if the paper has been written properly. But of course, you should be able to read it with a critical mind and be able to find errors and analyze the paper independently. The power of the paper could be judged by several surrogate markers. Where is this article published? What journal is this published? Here, the impact factor of the journal gives a very good guide. An impact factor of a journal is essentially the number of times an average article in that particular journal is cited every year. For example, one of the most prestigious journals in clinical medicine, like New England Journal of Medicine, the impact factor, the going rate is about 73. It's, unbelievably high. Whereas most specialized journals, it could be as low as 2 or 3. So, and then it is also important for you to realize that in preprints, this is an entity which people in the publishing game is very well aware of. Preprints are of very little value when it comes to analysis, because unlike in a published article, preprints have not gone through the process of peer review. So preprints are very important for the writer because it is a kind of platform to advertise your work. even before it is published. And this is a relatively new phenomena, but when it comes to the actual value of the work, this is of very little value. Who are the authors who have written the paper? If it's an eminent group who is working in the field, you know that the work could be trusted. Whereas if, of course, if it's a maverick who has a reputation of coming up with the stranger things, you should, read it with caution. Which institute is doing the work and which country is producing these results? Again, this is a double-edged sword. There can be bias, and of course, allegations of racism is often raised for very valid reasons. Now, the effective order to read a paper, well, this depends, is very variable. Very often, all of us, including the reviewers, would read the abstract first, would read the conclusions. A good introduction will set the tone as to what the paper is all about. Identifying the aims and the objectives of the study, again, will give you an idea about the paper. Now, when you read the results, it is very important that you first read the graphs and the tables with the legends without reading what the authors have written. A good paper, if written originally by people who know the game very well, would have standalone graphs and tables which will explain the results lucidly. And that alone will sell the paper. And then you can, once you look at the graphs and the tables and you understand what is meant in the results, then you can read the results as reported by the authors and see whether what you understand by the results are very similar to what the authors try to say. Read the discussion, but of course, the crux of the paper would be the methods. Now, the methods is important because the numbers have to be adequate. You will see that in many studies, the fault is inadequate numbers. You are in a rush to publish and you don't design the study appropriately due to many constraints, financial or whatever, and the numbers do not really do justice to the study, the research question at hand. Is the population appropriate to the aim of the study? Were the controls the right controls for a case control study? Was the randomization done appropriately? And was the duration of the follow-up adequate? Was it an intention to treat study and a per protocol analysis? Was the appropriate statistical method used? Interpretation of the data, was it appropriate to the data shown? So these are the questions that you should ask yourself when you analyze the paper. Now with this, I will try to go through a few studies and interpret it in my way to see how they stand in judgment in the eyes of an internal medicine doctor. And Dilip, of course, would look at it from a biostatistician's point of view later on. Now, everybody is so clued up about COVID these days. So I picked up a few COVID studies to begin with. The recovery group's dexamethasone study, which everybody I'm sure is very familiar with. Dexamethasone in hospitalized patients for COVID-19, published in the New England Journal of Medicine in February 2021. Now, the recovery is a group essentially based in the clinical trials coordinated by the clinical trials unit in Nuffield, Oxford, which set base and started an ongoing study from early 2020 with the unfolding of the epidemic or the pandemic of COVID in the UK. Now it's actually international, spreading to Nepal and Jakarta as well. For the dexamethasone, which is only one part of the recovery group's publications, this was a study which was done in UK with 175 hospitals participating. The objective of the study was to see whether the use of the anti-inflammatory drug dexamethasone 6 milligrams used IV or orally will reduce the 28-day mortality in hospitalized patients. This was the primary endpoint of the study, which was very clearly defined. And this study also clearly defined its secondary endpoints. These are the words that you have to get to your mind while you read the paper. So the secondary outcomes that the researchers were interested to see in these patients who were in hospital, the ill patients, were the time until discharge from hospital. Amongst the patients who were not receiving invasive mechanical ventilation, at the time they were randomized into the study, how many of them ended up with invasive mechanical ventilation, or how many of them ended up dead? The cause-specific mortality, how many ended up with renal dialysis or hemofiltration, and how many developed major cardiac arrhythmias. They randomized 2 to standard care and 1 to dexamethasone. Now, interestingly, in this study, this is very revealing that at the beginning of the study, the researchers had no idea how many patients would come into the study, because the pandemic was just at the beginning when the study started. So they kept the number of patients open, and the actual number was delineated much later. So for those who do such ongoing studies, this is something which you have to realize. The number need not always be fixed at the very beginning of the study, especially in a scenario like this. And so this is what really happened. 11,000 patients were recruited, over 11,000 patients were recruited, and the strobe chart shows that almost 1,900 odd patients had to be excluded for valid reasons, and 9,355 patients underwent randomization to dexamethasone and other agents. So this is not purely a dexamethasone study for the recovery group. They were looking at many other agents like antivirals, hydroxychloroquine, and azithromycin. So they left them outside in this particular part of the analysis. So of these 6,000 odd individuals underwent randomization for dexamethasone versus standard care. And so from the 6,425 individuals who were selected for the DEXA study, 2,104 were assigned for dexamethasone, twice that much were assigned for standard care. Of this, certain numbers withdrew consent, and several people dropped out. However, the important thing is, for the final analysis, all 2,104 were considered for analysis. This is what is called intention to treat. So even though some people withdrew, they were also considered for the analysis. So the primary outcome was the 28-day mortality, and the hazard ratio from the Cox regression was used to estimate the mortality rate ratio and for the cumulative mortality over 28-day period. And now the important thing is to make sure when you do this stratification that your patients and the controls are similar. Now this study is, I am sure even for you, this looks very difficult to read. Now, when you compare the dexamethasone and the usual care, you look at the age of the dexamethasone and the usual, you find that both of them are very similar age group. And most of the patients are actually quite old. The mean age is around 66 and very similar age groups. The vast majority of the patients are under 70, but overall the age group is quite old. So this is the vulnerable group that we are interested in bad COVID. And 64% of the individuals were males, 36 females. And like in United Kingdom, as it would show, the majority of the patients were white, but the ethnic minorities were also considered for this study. And then they looked at the mortality using Kaplan-Meier survival curves, and this is what they essentially found. The dexamethasone arm across the time period and even at 28 days had reduced mortality compared to the usual care. So when you compare with dexamethasone versus usual care, The primary outcome, the most important thing that they concentrated was mortality at 28 days, which means it is what is a good number. And there were many other factors which favored the use of dexamethasone. For example, invasive secondary outcomes, invasive mechanical ventilation or death were also less. Several other things, use of ventilation, need for ventilation were also less. Non-invasive ventilation was also less. Renal replacement therapy was also less. So dexamethasone was coming up on top compared to standard care. To sum things up, in this study, out of total of 2,104 patients randomized to dexamethasone venous for 10 days, compared with 4,321 randomized to usual care. Among the patients who received usual care alone, 28-day mortality was highest in those who required ventilation, intermediate in those who required oxygen, and there was very little benefit in those who had no respiratory intervention needed. And they went on to analyze this further and to say that dexamethasone reduced the deaths by a third in ventilated patients. Rate ratio was 0.6, by a fifth in those who received oxygen, rate ratio 0.8, but there was no benefit in using dexamethasone in those individuals who did not need respiratory support. Rate ratio was more than 1. So based on these results, the number needed to treat one death could be prevented by treatment of around 8 ventilated patients or around 25 patients requiring oxygen alone. So the analysis of this study, it's a randomized study, but it was not a double-blind study. It's a placebo-controlled study where, yes, it was the endpoints were very clear. And these are, it's one of the strongest points of this study because it was looking at very hard endpoints like death. The numbers were very good. It was looking at very large numbers. And the most important thing, especially looking back at this is a practice-changing study. So the strengths of the study are that it's adequate numbers. Well, it does represent all races, but definitely less ethnic minorities than the others. Proper randomization. Endpoints are clinically relevant, hard measurable endpoints like death, not based. The negative ones are this is an unblinded study. The patients and the doctors knew exactly who was getting what, but this you could always argue that this was offset by the large number and the hard endpoints. You know, you're looking at death, so it didn't really matter whether you are giving dexamethasone or whatever. And in the end of the day, it was a practice-changing study. And one of the major criticisms that I found was what was you given for the control arm is not listed anywhere in this study. And another strength, of course, is written by the British, is very, very clear language. Paper and the graphics is very, very easy to understand. And then with this, I'm getting into hot water here, ivermectin. Now, ivermectin is a very controversial subject, especially in the group. It's an antiparasitic drug. It's a central drug listed by the WHO, used for river blindness, onchocerciasis, tonsillitis, used in veterinary medicine for parasitic diseases. Now, the interest in this drug for COVID was because of this publication by a group in Monash, which showed that it shows antiviral properties. And there's attempts to repurpose this for COVID-19, like for almost all the other drugs. None of these are COVID drugs. Every drug is kind of repurposed for COVID. Right now, the scenario for ivermectin is very much like Donald Trump and HCQS time. And there's a lot of conflicting evidence, and people are very impulsive and opinionated about its benefits and pros and cons. So the supposed antiviral effects are, well, not very clear, but people argue out about the pathophysiological basis of its use. Now, the target of using, the objective of using ivermectin is mainly for the mild to moderate disease to shorten the disease, or to achieve PCR negativity, or also to prevent progression of the disease in the case of severe disease. Now, multiple trials, more than 40 trials are available, including meta-analysis and a Cochrane data analysis. But still, for all, the data is still quite unclear, and because of the disparities of the studies. Now, with this, I will take on a few studies about ivermectin. One such study originating from Turkey, which was published in BMC Infectious Diseases in May 2021. Now, BMC Infectious Diseases has an impact factor of 2.8. Now, the team and the nation credibility, we don't know. But what we definitely know is that this is not Didier Rao, or the, the maverick of HCQS, hydroxychloroquine. So, we really don't know who this group is. I'm sure the infectious diseases people do know, but I don't know. Now, the trial is a prospective, randomized, controlled, single-blind, phase 3 multi-center clinical trial done over a period of about 5 months, essentially assessing the effectiveness and safety of ivermectin for treatment in patients where ivermectin without negating mutation is there. Now, these people were very specific. They identified pharmacological biospecific marker which makes ivermectin ineffective, and got rid of people who had that single nucleotide polymorphism, which made ivermectin ineffective on those people. So this is importantly a drug, a trial which was used for patients with severe pneumonia and COVID-19. And randomized, they started with the first patient, one for odd numbers, one for the even numbers. So it's a randomized control study, and the control group, everybody essentially got hydroxychloroquine, antiviral, azithromycin for everybody. In addition to that, the patients received ivermectin for 5 days. And during the study period was divided into 2 phases of 5 days. The first 5 days with ivermectin, and the second 5 days after ivermectin. And in the first 5 days, they measured clinical and laboratory parameters on the first day, the third day, the fifth day. And in the next 5 days after ivermectin, they again measured these parameters on the first day, the third day, and the fifth day. And they also observed for side effects. Now, the endpoint was clinical response. The clinical response, and they also looked for side effects. So the primary response here was clinical response, not death. Clinical response was defined clearly as extubation in ventilated patients, a respiratory rate less than 26, an oxygen saturation more than 90% on room air, a PaO2 FiO2 ratio more than 300 in patients who were receiving oxygen, or a presence of at least 2 of the 2-point reduction criteria in the SOFA score was considered to be a clinical response. So this is the first 5 days, the presence of these were considered to be markers of clinical response. And for secondary response, they were measured in the second 5-day period. A clinical response or side effects were considered. Again, similar parameters like respiratory rates, oxygen saturation, or absence of oxygen requirement were considered in the second 5-day period. And they also looked at certain laboratory markers as secondary response markers. Statistical evaluation, which Dileepa is going to go into, they calculated the sample size using a formula, and this is the patient characteristics. Total number was 60. Study group had 30, control had 30, and the gender, well, essentially, the age group was, about the vast majority were males, 70% and 63% in the control and the study group. The mean age of both groups were 58 and 66, which was not statistically significant. And the vast majority of these patients had comorbidities. As you could see, 33% had diabetes, 40% had hypertension. So they were looking at the right group of patients whom we are interested in when we are assessing severe disease. So of a total of 66 patients, there were initially 36, of which 6 were removed because of the presence of a single nucleotide polymorphism, which negated the effects of ivermectin. So they ended up with 30 in the study group and 30 in the control group. And at the end of a 5-day period, the primary endpoint, they found clinical improvement in 46% and 36% in the control group. At the end of the second 5-day period, after ivermectin was used, further clinical improvement was seen in 73% of the patient group and 53% in the control group. So there was a clear difference supporting ivermectin. However, this was not statistically significant. Now, 6 patients in the study group, 20%, and 9 patients in the control group, 30%, died during this period. This again was not statistically significant. So the authors in this Turkish study concluded by saying, by adding ivermectin to standard therapy, higher rate of clinical improvement could be achieved. And they concluded that this clinical improvement and mortality differences between the study and the control group was not statistically significant, which was true, but these differences could be improved if you could repeat this study with a larger number of patients. Now, this is something which we will hear more and more. So it's a randomized study, single-blinded. The doctors were aware because doctors had to be aware because they were giving ivermectin only to those people who didn't have the mutation. So patients were not aware. Randomization was done. Endpoints were clear, but they were using clinical response, and which was a very measurable clinical response. Numbers were very, very small, and the observations were good. And the final comments were fair, but at the end of the day, nothing much could be deduced from this study. One more about ivermectin, the Bangladesh study or the Mahmood study, which was published in the Journal of International Medical Research. It's not a predatory journal. It's a Sagi publishers with an impact factor of about 1.2. Yet again, the fact that I don't know about the authors does not mean anything. They may be a reputed set of infectious diseases specialists from Bangladesh. And the study was a short study of a duration of about 3 months last year in Bangladesh, where older patients more than 18 years who were PCR positive with mild to moderate. This is not severe COVID though, remember, this is a mild to moderate COVID infection, were recruited for the study. Investigator-driven randomized placebo-controlled study, where ivermectin and doxycycline together, in addition to standard care, was given to the treatment group, and the standard treatment include an amazing concoction of drugs, including paracetamol, antihistamine, cough suppressants, vitamins, oxygen when necessary, low molecular weight heparin when necessary, and remdesivir, and other antiviral drugs. Now, this is another thing which we see in these studies. And so it is placebo arm versus this ivermectin and doxycycline in the other study. Now, date of random assignment was considered as day 1. And all patients, so there were two groups of patients who were followed up as outpatients and the others who were followed up as inpatients. And all patients received the initial study at intervention day 1. And outpatients were followed up for at least 3 days after clinical recovery. Again, this is a clinical recovery study. And the hospitalized patients were followed up for a period of 14 days until discharge or clinical improvement, whichever occurred later. And laboratory tests were followed up at different sets of time. And here the outcomes were the number of days that is required for clinical recovery from day 1. The secondary outcome was the progression of the disease from through mild, through to moderate, through to severe, or to death. And another secondary outcome was defined as the proportion of patients who continued to test positive for COVID-19 on day 14. So the primary outcome here was the days required for clinical recovery. So again, a rather a soft definition when you're dealing with a mild to moderate COVID rather than severe COVID here. And mild and moderate and severe, they use the standard WHO definitions. And this was defined as an intention to treat analysis. And this again will be dealt by Deepa. So there were 556 patients at the beginning. 156 were excluded for not including not having the desired criteria, of which ultimately 400 fitted into the study. So 200 went to placebo, 200 went to the standard drug, and they were followed up for the duration. And 17 were lost to follow up in the placebo, 15 were lost to follow up during the study. And strangely, though it's defined as an intention to treat analysis, you find that only 180 out of the 200 is analyzed at the end. This I find a little bit strange here. And this slide shows you the patient characteristics of these two groups. And this is something very interesting. The mean age of this the study is 40 years in the patients and 41 years in the treatment group. 62% of the study population is less than 40 years. This is a very young age group which has been selected for this study from Bangladesh. And when you look at the other striking thing of this study group is that very few percentage of people have comorbidities. So mild to moderate disease in a young patient cohort with very few comorbidities. And as you can see, 71% have mild disease. So it's a very selected mild disease group which has been studied. And then they look at recovery. So clinical recovery here is defined as normal body temperature for at least 3 days, improved respiratory symptoms, defined as no shortness of breath or respiratory rate below 25, and oxygen saturation more than 93 without supplemental oxygen. Now, very subjective criteria, some of them. And so this is one of the problems in this kind of a study. And then they looked at time to recovery in these patients. And this looked at the advantages of the study group versus the control. And essentially, the conclusion was patients with mild to moderate COVID-19 treated with ivermectin in combination with doxycycline recovered 2 days earlier than those who were treated with placebo. And the same thing continued. The proportion of patients responding within 7 days of treatment was significantly higher in the treatment group than in the placebo group. So basically the theme continues, and the authors go on to say that the combination of doxycycline and ivermectin might play a role in the early recovery and viral clearance, thus reducing the need for hospitalization and quarantine periods of patients. Now, The conclusion of this study is that adult patients with mild to moderate COVID-19 infection treated with ivermectin combined with doxycycline recovered earlier than those receiving placebo, and they were less likely to progress to serious disease and were more likely to test negative for COVID-19 at the end of the treatment period. And the safety and efficacy of these combinations are favorable compared with the current standard of care. Now, when you look at this study in great detail, you find that 90% of the patients here are under the age of 60, mostly under the age of 40, is very much like the Navy cluster we had during the second wave. And overall, the milder diseases, here they say reduce hospitals stay. So whether it really is a fantastic observation needs to be assessed. So in these 400 patients with mild disease, given the drug, 48 had deteriorated. Of the 48, 32 were in the placebo arm. And the worst deterioration had to be managed with only with oxygen. No one had very bad disease. The worst they had was moderate disease. And strangely, no one died. And now, when I look back at the statistics in Bangladesh in the same period, in 2020, July, August, this was a time when Bangladesh was reporting 3,000 patients with 50 deaths. And this study cohort didn't actually represent what was truly happening at that time. So this is just a personal observation. But besides that, that study has no major errors in the way it is written up. But again, this is where it is. It's a randomized, double-blind, open study. Well, it is not really double-blind, it's open, placebo control. There are, well, numbers are 200 and 200. Endpoints are relatively soft endpoints, and the conclusions are, of course, open to debate. The last on ivermectin is this infamous or famous Elgazzar study from Egypt. I'm sure most of you are aware about this. Elgazzar study never really saw the light of day as a published paper. It was in the preprint form, in the preprint format, Research Square. Research Square, as you know, is a multidisciplinary preprint and author service platform, which, as I mentioned before, authors love this because you can advertise your paper way before it is published. And this article never was published, and therefore it was never peer reviewed. But this was very striking results in this paper, and this has large numbers of participants. And the results of this, which favored ivermectin so much, it has been used in meta-analysis. So this is the problem with this using data from preprints for meta-analysis, which sometimes is not the right thing to do. Now, just a little bit about this Elgazzar study, which is no longer in existence, just so that you are aware about at least the history of medicine and sometimes corrupt practices of researchers. This is a study which, by this Egyptian group, looked at the usage of, essentially compared ivermectin with hydroxychloroquine in the treatment of mild to moderate and severe COVID for treatment as well as for prophylaxis. There are a significantly large number of patients, 600 subjects, 400 symptomatic patients, and 200 contacts for prophylaxis were assessed. Now, there were 6 study arms, 100 mild to moderate COVID patients who were given ivermectin, 100 mild to moderate COVID who were given hydroxychloroquine, 100 to severe COVID infection who were given ivermectin, 100 severe COVID who were given hydroxychloroquine. And the 5th group was contacts who didn't have COVID, who were given ivermectin to see whether they will develop COVID. And the other group was only given PPE and was to see whether they will develop COVID. And the results were very striking. In fact, when you compared hydroxychloroquine versus ivermectin, it really supported ivermectin by preventing mild to moderate disease improvement 99% versus 74%, 99 to 74%. Deaths were 0% in versus 4% in ivermectin. When you looked at the severe COVID, improvement was 94 versus 50%. 50% improvement in hydroxychloroquine, 94% improvement in ivermectin. Deaths were 2% in ivermectin and a staggering 20% in hydroxychloroquine. So this was a damning thing for hydroxychloroquine, but very supportive for ivermectin. And it was also very supportive for using ivermectin for chemoprophylaxis, because household contacts who used ivermectin, the positivity rate was only 2%, whereas if you didn't use it, it was 10%. The problem with this was, despite all this very, very beneficial thing, falsified data was figured out by lots of people. Out of the 600 so data, 79 data was shown to be falsified or intentionally changed, and Research Square had to retract the publication. So this is one of the things which kind of ugly research, where retraction has to happen. Remember, this happens not at the preprint stage. Sometimes retractions happen even after publication. This, you know about the famous, infamous situation that even the big journals like Lancet had to face very recently. And finally, from my side, leaving COVID as a relief and coming to thalassemia, trying to explain divergent results in a thalassemia study. Now, thalassemia is a blood disease, and when you look at patients with thalassemia, few publications in 1979 reported that in patients with thalassemia, MRIs showed white matter changes, or what are called small vessel disease changes, which we internal medicine doctors are quite familiar with, which happen in some patients and we really don't know the significance of it. So these white matter changes had been reported in thalassemia patients in 1979. The clinical significance of these white matter changes in thalassemia patients had not been adequately studied. So in this backdrop, ourselves set up a research study, I think in 2014, and looked at the neurological manifestations of thalassemia patients in Sri Lanka. And so what these white matter changes are, like these little white dots, which you might see in an MRI, or could be as shocking as these periventricular changes, which you could see in a 20-year-old thalassemia patient. And so the study, which ended up being published in 2019 in British Journal of Hematology, essentially was a case control study in the British Journal of Hematology with an impact factor of 5.5, was a study where we looked at neurological manifestations of thalassemia patients. And then we compared these neurological manifestations with a control group. So we looked at particularly headache in the thalassemia patients, where a specialist neurologist interviewed all the patients. And cognitive function of all the thalassemia patients was also assessed by a specialist psychiatrist. And all the patients and all controls with the headache underwent MRI. And this is essentially 82 patients with thalassemia who are older than 18 years with different types of thalassemia, and 80 controls were recruited for this study. And this is what we found. 61% of thalassemia patients had headache compared to only 22.5% of controls, a staggering difference which was statistically significant. So thalassemia patients were found to have a large, very significant high prevalence of headache. And when we did the MRI, we found that MRI changes were found in 24% of thalassemia patients, and the MRI were done in 29 controls, everyone with a headache and a few more, 6.9%, which was not statistically significant, just kind of barely not significant. But what was more interesting was when we looked at the thalassemia patients who had headache, they also had a lot of white matter changes. So not only did we find that headaches were more common in thalassemia patients, and the headaches seemed to be associated with white matter changes, which was very statistically significant. And that was the crux of the paper. And this had not been reported before, and this is what we published. But almost on very soon afterwards, few months later, came this study from Italy. It said headache in beta thalassemia, an Italian multicenter clinical conventional MRI angiographic case control study, which was published in Blood Cells Molecules with an impact factor slightly less, 2.3, which was essentially replication of our study, a case control study. The objective is based on what we found, which had kind of disturbed them, so they decided to replicate them, the study. They interviewed 102, slightly more than our patient group, and 129. So we had 80, they had 100 and over 100. Essentially the same thing. And their results were so different. Headache prevalence was 38%, ours was 61. And the controls headache was almost the same. So there was no difference of headache in the patients versus the controls. And on top of this, white matter changes were not associated with headache in the thalassemia patients. It was completely the opposite of what we found. Now, how could you explain this? Now, so they conclude that in Italian beta thalassemia patients, headache does not seem to be more common or severe than in the general population, and white matter changes are not associated in that in ours. So, is it one group doing something which is not right? So, why are the results so divergent? This is really, really baffling. So, when you look at the study cohorts carefully, you will find that this is our study group. Thalassemia major, ETAL, thalassemia intermediate, this is the study group. When you look at the patient characteristics, when you very closely look at them, when you look at hemoglobin levels, our mean hemoglobin level of thalassemia major is 8, ETAL is 6.7, thalassemia intermediate is 7.6. And this is the Italian data. And if you look at it closely, their mean hemoglobin level of the thalassemia major is 9.2, almost a gram higher. And surprisingly, in their intermediate group, where ours was 6 grams, their hemoglobin is even higher than of thalassemia major, 9.6. So the patient cohorts seem to be very, very different. And this is their white matter changes. So when you compare the patient cohorts, when you look at the ages, they are very similar, Italian and the Sri Lankan. The mean hemoglobin was 6.7 in the Sri Lankan, 9.6 in Italian, 8 in thalassemia major in Sri Lanka, 9.2 in Italy. The iron, of course, again showed the major difference, but iron and headache, no one can think of a reason. But hemoglobin and headache, though we in multiple regression analysis, hemoglobin did not come as an important factor in the Sri Lankan study, probably because the numbers were so limited. This was the major difference. Now, why the controls are so different? In the controls, the headaches were 22%. In the Italians, the controls had more headache. And the white matter changes were only 6% in ours. 43% of Italians had white matter changes. This is very difficult to answer based on the information we have. So how could you answer questions like this in rare diseases, where the numbers are now COVID, of course, you can improve the studies by recruiting thousands of patients where unfortunately we have very, very large numbers. But in rare diseases like thalassemia, where the numbers are limited in most countries, I think the way forward would be by pooling data from multiple centers or perhaps in multiple countries of similar groups, for example, in South Asia, or when you do cluster studies from Mediterranean, and not to generalize management for thalassaemia like diseases, but have geography specific management to be thought of when you are dealing with specific diseases. I think I will rest my discussion and hand over to Dileepa. Thank you.
Thank you very much, sir, for that excellent presentation. And now we move on to the second part of our webinar. And the resource person is Dr. Dileepa Edrivira. Dr. Edrivira is a senior lecturer in the Health Data Science Unit, Faculty of Medicine, University of Kelaniya. Dileepa graduated from Faculty of Medicine, University of Kelaniya, and has obtained MSc in Biostatistics and MSc in Biomedical Informatics. His PhD was on spatiotemporal modeling of snake bites and soil-transmitted helminths in Sri Lanka. Over to you, Dileepa.
Right. Thank you very much for inviting me today. Let me share my screen first. Is my screen visible?
Not yet. Now, yes.
Okay. Right. Good evening to all. So first, I'll give a brief overview of statistical methods which are being used in clinical studies, and then I'll go through the statistical methods and results in the selected studies which Prof. Anuja presented. Right, so hypothesis testing. So going beyond p-values, so we usually see research studies presenting only the p-values, but for us to get an idea about the implications or the effectiveness, we need to have some sort of a idea of the effect sizes, or to see the clinical response, or the how clinically it's important, whether the p-value or statistical significance is enough, or do we need something more than that. So if you look at the effect sizes, usually we present effect sizes with 95% confidence interval. So then we can get an idea, okay, so how large is these effect sizes, whether it's just over 1 or whether it's more than that, something like that. So usually for effect sizes, we present the relative risks or ratios, hazard ratios, or even correlation coefficients or coherence D. So these are the popular the measurements of effects. And also in clinical research, especially in clinical trials, the number needed to treat and number needed to harm are very important to assess. The number needed to treat is how many patients would you need to treat with intervention A instead of intervention B before you would expect to encounter one additional positive outcome of interest. So usually we prefer to have this NNT at single digit. That means, so if our NNT is 9, that means if we treat 9 patients, we get an additional benefit, something like that. On the other hand, we have a number needed to harm. So which means how many patients would you need to treat with intervention A instead of intervention B before you would expect to encounter an additional outcome of interest that you would like to avoid. So these are something we would like to see in papers, especially in clinical trials. So this slide shows some sort of get an idea about how these effect sizes can be interpreted. So example, if a study reports relative risk or ratio, hazard ratio of 2, that shows that's a small effect size. But if we can see something like 4, effect size of 4, that means that's a good study. That not a good study. I mean, the intervention has a large effect size. So that's something we need to see. Whenever clinical research present an effect size, it should be something close to 4 or something between 2 or 4, something like that. Again, there are some absolute measures like attributable risk which is something on, again, the risk difference between two interventions. Again, the small effect size is something less than 10%, but the effect, the attributable risk is more than, let's say, 33% to 50%. We generally say it's a good, it's a large effect size. Similarly, the NNT, if it is more than 10, we say it's a small effect size, but if it's like 2 and 3, that means it has a very large effect size. So there are other measurements like area under the curve and so on, but mainly in day-to-day life, what we see is relative risk or ratios, hazard ratios. Those are the 3 common effect sizes we see studies being quoted. Right, the controls. So this is something very important to see whenever we read an article. So this is sort of a yardstick to see the, this gives us the reference group to do our comparisons. So usually, especially in the efficacy and effective trials, we need to see the controls, whether these are placebo controlled trials, or they are getting the standard usual of care. So we need to see how the controls are being used in the study. The reason is usually when patients get into a study, patients' expectations, enthusiasm, feeling of inclusion may in turn affect their judgment, feeling of well-being. So this is something we need to consider when we do the analysis or when we interpret the results of a study. Having a control also enable us to get an idea about the time trends, especially to get COVID. We know with time people recover. So without a control arm, we won't be able to assess these. So it's very important to get an idea, to have a control group to get time trends. And also there's a concept called regression to mean. That means if we follow up a group of people, with time, they tend to regress or move towards the average values of the group, of the cohort. So this is very important to see whether when we interpret a result or when we analyze, whether this is due to the regression to the mean concept, whether it's there, or whether we see something due to the intervention. To assess these, we need to have a good control group. So whenever we read a study, we need to see, are these controls acceptable, whether they are comparable, whether we can use these to interpret our results. Right, the choice of analysis. As we all know, when we conduct a clinical trial or even a study, there will be dropouts. Sometimes this may be due to the adverse effects. So let's say in the intervention group, they may be getting more adverse effects. That may be the reason they may lost to follow up. They may withdraw from the study, or even you might have to switch the treatment. So it's always important to consider this in the analysis. There are 2 types of analysis. One is the intention to treat analysis, ITT, where we conduct the analysis as the randomized. So we get the randomized groups, even though they drop out or they switch the treatment, still we analyze them as we randomize. So this is very important to assess the effectiveness, especially to see the real world effect of a treatment. So now this is very challenging. Now, if we lose some people to follow up, now how to do this? Now, how to do this analysis? Especially in high impact journals, they ask us to conduct intention to treat analysis. There are a few ways to do that. If we have some missing values, so if we get some loss to follow up patients, we need to impute that data. We have to do some sort of a internally adjustment for that. Sometimes maybe getting the last follow-up date for the future the reading, something like that. So it's very important to consider intention to treat analysis. On the other hand, we have the per protocol analysis, where the analysis is based upon adherence to the treatment, that where we assess the true biological effects. Only the people who follow up the study will consider for the analysis, where that biological effect will be there. But on the other hand, the intention to treat analysis, we see the real world effect. Right. So when we go through those studies, you might see there are 2 types of analysis. I mean, mainly the statistical tests can be broadly divided into two, the parametric and non-parametric analysis. In those papers, they have mentioned non-parametric analysis. That's why I thought to include this slide. So the difference is in parametric analysis, we use some distribution properties to make our inference. Example, let's say if you are working on the systolic blood pressure, so we assume that has a normal distribution, and we know the mean, median, mode will be in the middle, the same, and within 2 standard deviation, 95% of the observation will lie. So we use those properties to make our interpretation or our testing. So whenever a test use a parametric distribution, underlying distribution, and based on that distribution, if they do come to a conclusion, then those are called parametric type tests. On the other hand, the non-parametric test, we don't use any distribution assumptions. These are called distribution-free tests. In parametric tests, we know the mean, median, and mode will lie in the middle. So therefore, we can use that mean to do comparisons. And the problem is, in parametric tests, whenever we get an outlier, the mean is sensitive to outliers. So then we might not get the expected results, or we can't use the properties of parametric or the normal distribution to draw conclusions. But on the other hand, non-parametric tests, they use medians which are not sensitive to outliers. So that's why mainly these two types of tests are there. In parametric tests, since we use some sort of distribution, these are generally more powerful compared to non-parametric methods. So those are the main differences. And for example, if let's say if you're going to do some group comparison, maybe pre and post, independent groups or intervention and controls. So these are the parametric and non-parametric the counterparts. So for t-tests, we have Mann-Whitney U-test, so on and so forth. So we have to be better to have sort of a general idea of these tests, then we can easily interpret the results. The regression type analysis. So, not like the group comparison, in regression type analysis, the main idea is to do a prediction. So these are the statistical processes for estimating a relationship between a dependent variable and one or more independent variables. Dependent variables are also called outcome or response variable, or independent variables are also called predictors, covariates, explanatory variable. If we consider only one independent variable, then we call a simple regression type analysis. If there are more than one variable, we call multiple regression analysis. And these regression type analysis helps us to get an idea to identify the factors which matter most, or factors which we can ignore in the analysis, and how those factors interact with each other. So there's something called interactions. When one variable is there, it can affect the other variables. When one drug is there, it could affect the other variables, something like that. So those are very important to consider. In a regression analysis, what we see is the average response in Y variable or average response of the dependent variable based on the independent variables. So broadly speaking, this regression analysis could be several types. If our dependent variable is a continuous type variable, then we use linear regression. If it is a binary type variable, yes, no, having disease, yes, no, then we can use logistic regression. Then we come to the Cox regression, where the interest is on event times. That's something different to the above two. And the fourth type are the extension of the previous, the linear or the logistic regressions. Here we call mixed effect models. And especially if you look at the high impact journals, they use these mixed effect models. These are also called hierarchical models. The difference is not like in linear regression models. In linear regression, we use a single intercept for the entire data set. Let's say if you are working on hypertension, working on systolic blood pressure, there may be patients with 140, and there may be some with 170 blood pressure, or even somebody with 90. the systolic blood pressure. So for all those patients, we use a single intercept in linear type regression. But in mixed effect model, we can use separate intercepts for each patient. So that there, the analysis is more stronger and will enable us to go extra yard. I mean, these are sort of an extension of the simple and the logistic type regression models. So it's very, it's sort of a, if you see a journal article discussing on the mixed effect models, that means so the analysis has gone down to a sort of a different level. This is a simple introduction. This is a example. So if you look at the linear regression, as we know, the dependent variable should have a continuous variable. It should be a continuous variable and should have sort of a normal distribution. And we can easily plot the independent and dependent variable. Here, this example shows the happiness versus income. When income increases, the happiness goes up, something like that. Now, here the important thing is, if we see a linear regression, under the estimate, we see something like this example. How to interpret this? When the income increases by 1 unit, the happiness increases by 0.7 on average. This is how we interpret a normal linear regression line. So this is the effect size in other words. So here it's in continuous scale, and what we see, 1 unit increase in the independent variable will cause 0.7 increase in the dependent variable. On the other hand, we have logistic regression where the outcome is 1 and 0. And here we need to expand this range to do the analysis. That's why we use this logit function. It's the log p divided by 1 minus p. So if we get this logic function, the operator, this will enable us to expand our working range from -infinity to +infinity. That is the reason. And once we do this logic transformation, we can nicely model our data as shown in the graph. Right. In logistic regression, here what we get is odds ratio. The odds ratio means odds that an outcome will occur given particular exposure compared to the odds of the outcome occurring in the absence of that exposure. Or else you can say outcome per unit increase in the value of the exposure. Here, if the odds ratio is 1, that means there's no effect. I mean, there's no additional effect. The effect is not there. If the odds ratio is more than that, that means the exposure is associated with the higher odds of outcome. If the odds ratio is less than that, the exposure associated with low odds of outcome. This is an example I got from internet, just to give an idea. Sometimes journals might articles might present this as it is. This is a direct logistic regression model. Here you get the intercept and you get the drug dose. What we need to consider here, or it's be careful, since this is a logistic regression, this is in log scale. This is not in odd ratio. So if you see something in a model, in a journal article with an intercept, be careful. Don't interpret this as odd ratio. You have to exponent or get anti-log to get the odd ratios. Again, the survival analysis. Here, what we do is we analyze time to event. Previously, what we analyzed was presence and absence of disease. We didn't consider time, but here we consider the time as well. Mainly, we use two methods: the Kaplan-Meier curves and Cox regression. In Kaplan-Meier curves, we usually use the curves to compare two or more groups, male and female, effect of intervention versus control, something like that. Similarly, in Cox proportional hazard regression, it's same as the usual regression. We have a dependent variable and independent variable, and we try to see the association, how to get the hazard ratios. This is an example of Kaplan-Meier curve. Here, what I wanted to show is, whenever we present a Kaplan-Meier curve, it's a good thing to give the 95% confidence interval. Then we can see, okay, let's say after 20 months, so these curves are getting apart, right? So that means we can see a clear benefit in treatment A. So it's, if you see a journal article with 95% confidence interval, that means that they have thought about that, and it gives a clear idea for the reader. And also it gives the p-value of less than 0.001. So this is something to consider. And if you see Kaplan-Meier curves overlapping, I mean, or crossing each other, that means the effect is not there, or that's not significant anymore. So if the curves are not crossing each other, that means there's significant effect on the groups, or there's a significant difference between the groups. So whenever you look at the article, so see whether these are crossing or not. If they are crossing, that means this is not significant anymore. Similarly, we can present the same curves in cumulative incidence as well. Here again, we can see the curves are not crossing, and we can see a p-value of 0.002. So there's a significant difference between these two groups. Right. The Cox regression output, this is a bit complex to the logistic regression. The reason is there we get something called baseline hazard, which changes with time. So even without anything, any treatment intervention, the hazard function is there. So people will get the adverse outcomes that will reflected in the baseline hazard. And on the other hand, what we we are interested on the hazard ratios, the relative risk of event occurring at time t. Same as odd ratio. If the hazard ratio is 1, that means there's no effect. If the hazard ratio is less than 1, that means the effect has reduced. And if it is more than 1, there's an increased hazard due to that the variable. Again, I wanted to show this. Sometimes the software directly gives these estimates in log scale. So we need to exponentiate or get the anti-log to get the hazard ratio. So we have to be a bit careful. Sometimes we might mistakenly present these. So once you get the anti-log, the signs and the effect sizes get changed. So always be careful when interpreting a Cox regression model. Right. So going back to these previous studies, which Anuja mentioned, I thought to go through the methods and see what they have done and how can we interpret them. In the Dexamethasone study, they have done survival type analysis, mainly used Kaplan-Meier curves and Cox regression. So looking at this graph, you can see the death at 28 days is 0.83. And what the important thing to notice is here the confidence interval doesn't cross number 1. That means it has a clear effect. So that, or else we can say there's a 17% reduction of deaths at day 28, and the confidence interval doesn't cross 1. So if you look at all these numbers, so the second one, the discharge from hospital within 28 days, it shows the risk ratio is 1.1. That means there's a 10% increase in discharge rate within 28 days. And again, this doesn't cross 1. So that's how we need to interpret this. So we can see the risk ratios, and if now here they don't give the p-values, but still looking at the confidence intervals, we can interpret the results. And importantly, these curves, the survival curves, we can see there's no crossing over of these lines. So these are very divergent, and except the last one, these are getting apart with the time. So that shows there's a significant improvement with dexamethasone. For the group with no oxygen receives, this only crossed the 2 lines. So others they didn't cross, and also these showed a significant effect. So this is how to interpret the results. And the other study on ivermectin, which is published in BMC infectious disease. Here So they have used the computer program called G-Power. It's a software to calculate sample size, and it's a well-known software, and the original articles has more than 30,000 citations. So they have used, but unfortunately, they have not cited this the software. So in the article, so I think it's always good practice to cite. Now, this I think this is one way we can see the credibility, whether they have given the proper citation acknowledgement for the original authors. And I wanted to show here in this study, they have used the non-parametric methods, the Friedman test, Mann-Whitney test. And as you all know now, these non-parametric methods are anyway, they are not powerful as the parametric methods. So this is something maybe a reason that we might not see a significant difference in the outcome. Probably they have used the less powerful methods. They have not mentioned why they used it. Probably the outcomes may not be having normal distributions, but this is something to consider. And also what I noticed in the original article, they have given these graphs. Usually in these sort of settings, we tend to conduct longitudinal type analysis. Here we consider time as well, rather than just comparing the initial and the last values. It's more powerful to do a longitudinal analysis where the mixed effect models will come into play. I think the authors have missed that part. So that's, I feel they could have incorporated that into the analysis, and probably if they did, they would have found a better, I mean, sort of a significant results in this study. On the other study, again on ivermectin, which is published in Journal of Internal Medical Research. So here, in the statistical analysis, as Prof. Anuja mentioned, they have conducted intention to treat analysis, but however, it seems they have analyzed those who completed the study. So this again was a question about the credibility of the study and analysis methods. And what I noticed was they have done survival type analysis, but they used logistic regression and Cox regression both. And I can't understand why they did it, because since they have the time to event as well, so they got the hazard ratios from Cox regression, but without considering the time, they use the logistic regression. So probably these are something to consider, and not clear why they did separate analysis for these two. Probably they could do Cox regression for both analyses. And again, the reading the article, what I feel, they separately mentioned the no corrections were made for multiple comparisons. Probably I felt this may be they included this statement due to the reviewers' comments. The reason is I'll explain in the later slide. Now, okay, they have provided Kaplan-Meier curves, and looking at the graph, I feel this is an SPSS output, and the numbers, the table below seems to be an Excel output. So this gives me sort of an idea whether they don't have, whether they are fall short of statistical software or person to do this. Probably again something we won't see in a good high impact journal. Probably in high impact journals, they do copy edit and they do these changes, but seems here they have used the author's the original file. So this is something again I feel a bit I was not comfortable to see this the graph in the article. And again here the post hoc analysis of subgroups, these results are not actually mentioned in the article. So I tried to read, but I couldn't find, and this graph was not clear to me why they have done. And because of this graph, they mentioned in the methods, the post hoc, the multiple comparison adjustments was not there. So that's why I failed. So they have done something, but later they found so they have not conducted proper analysis in this graph, and that's why they put such statement in there. So we have to be a bit careful doing post-hoc sort of analysis. Probably this again reflects they may be not having a person to do the analysis, or maybe not thought in that level. Yes. So again, on the research for article which was withdrawn, what I found was just reading the first paragraph in the statistical method. So they have started saying the correlation between the study groups were completed utilizing chi-square. So this gives me a sort of an idea. So the authors or the person who wrote this maybe not aware of the statistics. So that means usually we use chi-square test to see the difference or the between groups, not to see the correlation analysis. So usually the correlation analysis will be done by using Pearson's correlation or something. So using this, the first few words, you can get an idea, okay, whether they have done or consider or get a help from a statistician to do this analysis. So that I feel when you read the article, it's better to have some sort of statistical background. Then we know what is being done and we know how to interpret this. So this is what I thought to discuss, and I think we can continue with the questions. Thank you.
Thank you, Dr. Edrivira, for that informative presentation. There is one question posted in the chat. A participant has said that he has missed what Prof. Anuja said about the HCQ study and its authors at the beginning of the relevant segment, and wondering whether Prof. Anuja could repeat it again. Sir?
Just a minute, please. I don't think I mentioned anything about a HCQS study. My studies were on dexamethasone and ivermectin. I
think you mentioned about the author who did the HCQ study, probably that.
Which one was that? About
the first one, I think. You said it was like you mentioned the author, sir, who did the HCQ study. I think that's the one.
When I was talking about ivermectin introduction, I was saying that the the excitement about ivermectin is like like the excitement we had with HCQS early on. That's all I mentioned. As exciting, controversial, and political and whatnot. That's all I mentioned.
Okay, so thank you.
Yes, the picture of the man was Didier Rao, the the Massey man who showed the hydroxychloroquine to be beneficial, which Donald Trump picked on, and that became kind of world famous. And again, there was a lot of controversy about his data.
I think so. That's what they were asking about. There's another question from Dr. Edrivira. They have asked, what is the difference between R statistics and R studio softwares, and what are the benefits of using R softwares over SPSS?
Right. The R programming language is the statistical software or the base the program. R studio is we call it IDE, integrated development environment. That means it helps us to do the analysis. So, when you start typing the commands, it will pop up and it will ease our life. So it's R studio is sort of a facility they're given, but we use R programming language for the analysis. The benefits of using R over SPSS, I think R is an open source software, and so it's freely available, downloadable, and especially for countries like Sri Lanka, so we can't afford the private the softwares like SPSS. Number one. Number two, for R, since it's an open source, there are a lot of help. So almost all the analysis you can easily find free libraries. If you want to do a Cox regression, we can find a library. So R comes with a base software to get some basic analysis. Example, doing a simple linear regression, logistic regression. But if you want to do something else, example, to do a hierarchical model or the mixed effect model, there are a lot of packages. And also it's a graphical software. You can produce nice graphs, not like SPSS. Like SPSS is a point and click software. It's your options are very limited, but when it comes to R, it's I can't. So there are a lot of help and packages, and there's virtually no limit for R. So that's what I see.
Thank you, Dr. Devere. Well, in the absence of any other questions, we would like to conclude the webinar today, and I would like to thank the two resource persons, Prof. Anuja Premawardana and Dr. Dilip Ediravera, for their valuable time during a weekend. And I thank all the participants for their time and for participating in this webinar, which helps us to read a research paper more critically. Thank you.
Thank you. Thank you very much.
Very much.
Thank you, Anuja, and thank you, Dileep. Thank you.
Thank you. Thank you, Tushar. And
Thank you.